Hello, my name is Benjamin King. I'm a fourth year medical student from Du Bois University, and today we'll be talking about selective serotonin reuptake inhibitors. I chose this topic due to some confusion on my part. Just how do clinicians and physicians choose one SSRI over another SSRI? And so I wanted to dig into this, and hopefully this can help someone else. So what are SSRIs? Obviously, it's in the name. They're selective serotonin reuptake inhibitors. So they block the serotonin reuptake transporter, enhancing how much serotonin's in the synaptic cleft and available to potentiate that action onto the postsynaptic cleft or the nerve receiving. There are 6 commonly used SSRIs: fluoxetine, sertraline, paroxetine, fluvoxamine, citalopram, and escitalopram. I've also included 2 atypical SSRIs, vilazodone and vortioxetine. You'll often see them included with the SSRIs, but they aren't straight or they aren't strictly SSRIs. They also have additional 5-HT1A partial antagonistic properties. I won't be talking about them today, but just to be aware if I wanted to list them for completeness sake. The indications for SSRIs, there's a broad list of conditions. Major depressive disorder, their first line. They're used for GAD, OCD, PTSD, as well as several others. These are just a small number of the indications for SSRIs. Why do SSRIs matter? Well, in the context of depression, there are a lot of adults as well as pediatrics or kids using antidepressants. SSRIs are the most commonly prescribed medication for depression, and they're the first line for 3 reasons: safety profile, the tolerability of the medication, and the effectiveness of the medication compared to other antidepressants such as serotonin norepinephrine reuptake inhibitors, monoamine oxidase inhibitors, and tricyclic antidepressants. So this was a study from the National Health Interview Survey in 2023. They found 11.4% of the population were using antidepressant medications, and kind of stratified, who are using them at higher rates. So women are twice as likely to be on an antidepressant. White or multi-race adults are more likely. Adults with disabilities are 3 times as likely. Those living alone, those from lower income families, and those living in the Midwest or rural areas are more likely to be on an antidepressant. So what are the common side effects of SSRIs? These are potential side effects. I shouldn't say common. Some more common than the others, and I have them listed into early side effects and late side effects. These are mostly for simplicity's sake. However, it's important to remember that these side effects can occur at any point in treatment. So diarrhea, nausea, and vomiting are often an early side effect. They can be activating, causing agitation, insomnia, and anxiety in the patient. And there's an increased risk of suicidal ideation. There's a black box warning for those under 24. SSRIs can cause sexual dysfunction, SIADH, or hyponatremia, electrolyte imbalances leading to cardiac arrhythmias. Serotonin syndrome, which is a life-threatening condition due to increased serotonergic activation in the central nervous system. We'll talk further in detail about this later on. Their use can lead to motor disorders, such as tremors, bruxism, which is teeth grinding, and they have the potential to lead to manic episodes in those undiagnosed with bipolar 1. There's a multitude of drug interactions, including monoamine oxidase inhibitors. It's kind of like the first category or class of drugs that we think about, the antibiotic linezolid. Some herbal supplements, such as St. John's wort, which is commonly used for depression, dextromethorphan, meperidine, methylene blue, warfarin, and NSAIDs. I listed warfarin and NSAIDs. They do have interactions. They can lead to increased amounts of these drugs, leading to bleeding risks. However, SSRIs also have an increased chance of leading to bleeding just due to their effects on platelets. They lead to decreased aggregation of platelets due to the serotonin receptors found on platelets. So I found that very interesting. There's multiple reasons for that increased risk of bleeding. So we're going to talk about each medication individually, starting with fluoxetine. Brand name is Prozac. So the mechanism of action, very similar to the rest. However, it does have antagonistic properties at the 5-HT2C receptors. This can potentially lead to increased amounts of norepinephrine and dopamine neurotransmission. Dosing is 20 to 80 milligrams for GAD and MDD. It's a little bit higher for bulimia at 60 to 80 milligrams. It comes in a liquid solution. And the notable fact about fluoxetine, it has a long half-life. Fluoxetine has a half-life of 2 to 3 days, while the active metabolite, norfluoxetine, has a half-life of 2 weeks. Fluoxetine inhibits CYP450, 2D6, and 3A4. Inhibition of 2D6 leads to decreased effectiveness of codeine potentially, and increased plasma levels of beta blockers and atomoxetine. Inhibition of 3A4 leads to increased amounts of statin medications, including simvastatin, atorvastatin, and lovastatin. If we don't see effects within 6 to 8 weeks, we may need to consider a dose increase or switch to a different SSRI. If we do see improved symptoms or remission, we will continue treatment for 1 year. So some advantages of fluoxetine. It's great for atypical depression, those with hypersomnia, increased appetite. The generics are less expensive. And I forgot to mention that fluoxetine is available with a once weekly dose of 90 milligrams. So this can be very beneficial for patients who are non-compliant or would just benefit from the convenience of having once weekly dosing. It also comes in a single pill containing olanzapine, brand name Symbyax, that is used for bipolar depression, treatment-resistant depression, and psychotic depression. There's no taper needed for fluoxetine due to that long half-life, which is very convenient. You don't have to worry as much about withdrawal symptoms. However, if they do have withdrawal symptoms, it would be wise to reduce the dose slowly and taper. And I'll talk about how we normally taper the medication later on. Some disadvantages: it's less tolerated in panic disorders, anxiety disorders, and those with insomnia. That is due to the activating side effects of the medication. Not great for patients with anorexia, and it can cause flattening of mood and affect. Sertraline, or Zoloft, has mechanism of action. SSRI desensitizes 5-HT1A. It has mild ability to block dopamine reuptake, so enhancing dopamine effects, and it binds sigma-1 receptors as an antagonist. While we don't know the full effects of this receptor, the sigma-1 receptor, it is hypothesized to be involved with neuroplasticity and enhancing the effects of chaperone proteins to lead to correctly folding misfolded proteins within the brain. However, it's not fully known its effects. Dosing is 50 to 200 milligrams daily. Scored tablets are available in the 25 and 50 milligram tablets, as well as a whole 100 milligram. Oral solutions are available, recommended to give with 4 ounces of water, ginger ale, lemonade, or orange juice to make it more palatable. Half-life of the metabolite is 62 to 104 hours. It requires 2 50% dose reductions every 3 days. This is a common theme with tapering. It has weak inhibition of CYP450, 2D6, and 3A4 at low doses. Again, this is very similar to fluoxetine. I won't repeat myself. Advantages: great for atypical depression. There's decreased risk of hyperprolactinemia. Great for patients with fatigue due to the activating nature. Reduced flattening effects, potentially due to the dopamine reuptake inhibition. And it's pretty safe for patients that are post-MI or have angina due to that safety profile. Disadvantages: not well tolerated in panic disorders or anxiety or patients with insomnia, and it has some GI symptoms, so it can worsen GI symptoms in patients with IBS. Paroxetine, brand name Paxil, very similar mechanism of action with the addition of mildly anticholinergic properties and mild norepinephrine reuptake inhibition. Dosing is 20 to 50 milligrams, comes in a controlled release format with the dose slightly higher, and it can be used for vasomotor symptoms with a dose of 7.5 milligrams at bedtime. Brand name is Brisdell. Also comes in liquid formation. Half-life is about 1 day. And the trouble with paroxetine is it has nonlinear metabolism, so an increase of 50% of this medication can lead to a 2x plasma concentration. And the withdrawal symptoms are more likely due to that same property. This is due to paroxetine inhibiting its own metabolism. We can also see some inhibition of 2D6, leading to the decreased effectiveness of codeine and increased plasma levels of beta blockers and atomoxetine. Some advantages: great for patients with a mixed anxiety and depression presentation, patients with insomnia, as it can be a little bit more sedating. An early reduction of anxiety and insomnia can be seen in the first couple weeks. Some disadvantages: we got to think about renal and hepatic impairments. So a lower dose may be required at 10 milligrams a day, a max of 40. Patients with hypersomnia, not great. Patients with Alzheimer's or cognitive disorders, due to the weak antimuscarinic properties, leading to constipation, dry mouth, sedation, orthostatic hypotension. A higher risk of withdrawal with this medication due to its nonlinear metabolism. It's a little less activating and has a potential for weight gain. Fluvoxamine, or Luvox, FDA approved for OCD and social anxiety disorder. It binds sigma-1 receptor as an agonist, which is, as opposed to the other medication, which was sertraline, had that antagonistic property. Dosing is 100 to 300 milligrams a day for OCD, 100 to 200 for MDD. Initially, you want to start at 50 milligrams a day for 4 to 7 days, and then increase to that starting dose of 100 milligrams daily. Best take at night due to the sedation properties. Half-life is 9 to 28 hours, which is really wide. I also saw 22 hours while I was looking through, while I was doing my research and preparing my presentation. It inhibits CYP451A2, which leads to reduced clearance of theophylline and clozapine, requiring a dose reduction of these medications. Inhibition of 3A4 leads to reduced clearance of carbamazepine, benzodiazepines, so dose reduction may be needed as well, and increased concentrations of statin medications, leading to an increased risk of rhabdomyolysis. For patients who are smokers, they may need a higher dose of fluvoxamine due to just the metabolism of the drug. And then there needs to be caution when using or augmenting with clomipramine, which is often used for OCD, because fluvoxamine increases clomipramine plasma levels, and it actually decreases the conversion of clomipramine, the parent clomipramine, into dimethylclomipramine. And that parent drug has more serotonergic side effects, versus the metabolized dimethylclomipramine has more neuroadrenergic inhibition. So with fluvoxamine increasing the parent drug, we have an increased risk of serotonin syndrome, something to be aware of. The advantages of fluvoxamine: it's really well tolerated. One second. For patients with anxiety and depression, generally, a generic is less expensive. In the early reduction of anxiety and insomnia, what's hypothesized to be potentially due to the sigma-1 receptor agonism, may have lower sexual side effects. Some disadvantages: you got to think about the renal and hepatic impairments. Patients with IBS or GI complaints, those symptoms may worsen with this drug. And then the drug interactions, especially with clomipramine in OCD management. It is not FDA approved for MDD. Citalopram, brand name Celexa, FDA approved for MDD. It has mild antagonistic properties at the histamine 1 receptor, and comes in the inactive R enantiomer and the active S enantiomer. Dosing is 20 to 40 milligrams daily, and it can be given at any time of the day that's best tolerated. Parent drug half-life is 23 to 45 hours. Taper is usually not needed. However, if we need to taper, if the patient's having withdrawal symptoms, we can use that dose reduction of 50% twice, each for 3 days. It has weak inhibition of CYP450 2D6, which leads to, again, decreased effectiveness of codeine. And then we have to be wary of medications that are inhibitors of CYP450 2C19, which metabolizes citalopram. So if they're on an inhibitor, 2C19 inhibitor, we want to keep citalopram dose less than or equal to 20 milligrams daily. Advantages: it's a great medication used in the elderly population, patients who felt too activated or sedated with other SSRIs, and it may also have less sexual side effects than other SSRIs. Disadvantages: the key one to be aware of is increased risk of QT prolongation. For renal and hepatic impairments, consider a lower dose, and it may be less tolerated than escitalopram. And there's also less documentation of efficacy in anxiety. Escitalopram, which is the S enantiomer of citalopram, brand name is Lexapro. It's FDA approved for major depressive disorder and generalized anxiety disorder. Dosing is 10 to 20 milligrams daily. And it's more potent than citalopram. So 10 milligrams of escitalopram is roughly equal to 40 milligrams of citalopram. Half-life is 27 to 32 hours. Tapering is usually not needed. If tapering is needed, again, we see that decreased dose to 50% for 3 days, and we do that twice before discontinuing. There's no significant effects on CYP450 enzymes, which is convenient as a clinician. Don't really worry about drug-to-drug interactions as much. The advantages: best tolerated antidepressant, quicker onset of action potentially, is often used with augmentation due to less drug interactions and may have less sexual side effects than some SSRIs. We still see the increased risk of QTC prolongation, less than citalopram, however, and we also need to be wary of severe renal impairment, used cautiously, and hepatic impairments, max dose of 10 milligrams a day. And it tends to be more expensive than citalopram. Here's a chart showing a quick comparison. We see paroxetine is kind of lit up there, second from the bottom, with anticholinergic properties, sedating properties, orthostatic hypotension, and it also causes weight gain and sexual dysfunction compared to other SSRIs. The two activating drugs, fluoxetine, sertraline to be noted, QTC prolongation, citalopram, and GI toxicity, sertraline. Fluoxetine is pretty weight neutral. I didn't highlight it there, but that's also something to note. I'm going to quickly talk about some special populations: the pediatric population, elderly, and pregnant women, and those that are breastfeeding. So in pediatrics, we really need to consider the risk benefits of treating versus non-treating. We need to monitor very closely, looking for activating effects. This is a condition called pediatric behavioral activation syndrome, much more common in pediatric population versus adults. And we see some FDA-approved conditions here. So FDA approved for MDD, we can use fluoxetine, escitalopram, and OCD, fluoxetine, fluvoxamine, and sertraline. So we need to observe. We wanted to have close face-to-face follow-up with our patients for the first several weeks of starting an SSRI. We want to look for activating effects, manic episodes, and suicidal ideation, as there is that black box warning. So I did a quick little search into the black box warning of increased suicidal ideation, as I've heard some controversy around whether that black box warning was really required or research evidence-based applied. And so the FDA in 2004 called for a review of 23 antidepressant studies, published and unpublished, for multiple causes, including OCD, MDD, anxiety, and ADHD, and using multiple drug classes, so not just SSRIs. The meta-analysis included 4,400 pediatric patients. They found that in the placebo group, the risk of suicidal ideation was 2%, while those in the treatment group had a risk of 4%. So a 2% difference. Future studies, there was another subsequent study that included 27 pediatric studies and found an even lower risk. risk difference of less than 1%. The number needed to harm was 100 to 143, and the number needed to treat was low at 3 to 6. So it's hard to understand why that black box warning was applied. There's, obviously it was significant findings. However, I think it's important to remember the differences between clinically significant and scientifically significant. Just using the alpha 0.05 is not always what translates to what real world practice. Obviously, it's placed there for a reason. We need to monitor and warn patients of this potential. I also found it interesting that there was a study that looked at from 2003 to 2004, SSRI use decreased by 22% in the US, with suicide rates increasing by 14%, which is the largest jump since the CDC began collecting data in 1979. Similarly, in the Netherlands, they saw a decrease of 22% in SSRI use, and they saw an increase of 49% of suicides from 2003 to 2005. Obviously, correlation does not equal causation, but something that I think we need to be concerned about, something that we need to be aware of, obviously monitor for continually. So in the elderly population, they may tolerate a lower dose due to just changes in metabolism. They have a higher risk of SIADH, so you look out for electrolyte imbalances. And then consider drug-to-drug interactions, as this population often is taking a multitude of drugs. Polypharmacy is a major concern. So we utilize resources and drug-drug interaction software to ensure that we aren't increasing the risk of serotonin syndrome or other complications. And we want to avoid anticholinergic SSRIs such as paroxetine due to the orthostatic hypotension and sedating properties. For those that are pregnant, it's generally not recommended to be used during pregnancy, especially the first trimester. We need to weigh the risk of treatment versus the risk of non-treatment. So the risk of treatment, we look at the first trimester fetal development, and then concerns and complications at delivery, such as increased bleeding, potential for gestational hypertension and preeclampsia, and then also the drug discontinuation syndrome from the baby. So, and then we also need to weigh the risk of non-treatment, the recurrence of depression, the maternal health, and infant bonding. So this takes careful consideration and discussion with the patient between the healthcare professional and the patient themselves to kind of weigh the risk-benefit. For breastfeeding, some drug is found in breast milk. So if the baby has remarkable change in baseline, whether that's irritability or sedation, we need to consider whether or not we need to discontinue the drug or discontinue breastfeeding. So there is some concern there, but is generally relatively safe. Just need to be monitoring for that. I'm going to talk about discontinuation syndrome, as I've talked about and haven't really gotten into the details. So this is normally when patients are taking an SSRI for more than 4 weeks. And I use the mnemonic FINISH to remember some of the symptoms. So that includes flu-like symptoms, fatigue, lethargy, malaise, headache, diarrhea, insomnia, so not sleeping at night for more than 3 days a week, nausea, imbalance or gait disturbances, sensory disturbances, and hyperarousal. This usually occurs within the first 3 days of discontinuing, and the treatment is to restart the SSRI at the original dose and begin a slower taper. Serotonin syndrome, we briefly talked about that before. It includes symptoms of mydriasis, agitation, tachycardia, hypertension, which is kind of included within the autonomic instability, includes tremor, hyperreflexia, and clonus. So this is commonly caused by inadvertent interaction of drugs, potentially the intentional overdose of medications prescribed. And it can also be caused by just routine use of prescribed medication. Much more rare, but has been noted. So The diagnosis is a clinical diagnosis. We do have a criteria called the 100 criteria that can help us further diagnose in the clinic or the hospital. You can see here that would include obviously being on a serotonergic agent and then having spontaneous clonus would meet criteria, or having a tremor plus hyperreflexia. So a combination of these symptoms that's a validated criteria. A commonly mistaken condition that gets confused with serotonin syndrome is neuroleptic malignant syndrome. And there are quite a few overlapping symptoms, but I just want to clarify the differences between the two. Neuroleptic malignant syndrome develops over weeks to days and is characterized by rigidity and bradyreflexia and resolves within 9 days. While serotonin syndrome develops more rapidly within 24 hours, is characterized by a tremor, hyperreflexia, and myoclonus, and resolves within 24 hours. Some of the shared symptoms and features would include hyperthermia, elevated liver enzymes, and elevated creatine phosphokinase, as well as altered mental status and leukocytosis. The treatment of serotonin syndrome, we use benzos first line, and if that fails, we use cyproheptadine, an H1 receptor antagonist with non-specific 5-HT1A and 5-HT2A antagonistic properties. But obviously the first line, we need to discontinue the offending drug. I didn't mention that. We need to discontinue the offending drug and then use supportive care, whether that is supporting blood pressure, agitation, tachycardia, and the like. So thank you for listening. We talked about the SSRI indications, potential side effects, details of each SSRI, comparison of each SSRI, special populations, and some syndromes that we see, discontinuation syndrome and serotonin syndrome. Here are my resources. If you have any questions, please let me know. But thank you again for listening, and I'll talk to you next time.